Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Steve Riggs, and I'm excited for today's episode where we will discuss competition and collaboration in urology. Joining me today for this discussion is Dr. Alan Wein. Dr. Wein is Professor of Clinical Urology, Director of Business Development and Mentoring at the Desai Sethi Urology Institute at the University of Miami Miller School of Medicine. He was previously the Chief of the Division of Urology at Penn for 37 years. I believe many in our audience will recognize him as editor of Campbell's Wein Wash Urology textbook, but Dr. Wein has had a very distinguished career. I'd like to highlight three awards. One, the Edward Keyes Medal, which by many accounts is considered the single greatest individual citation in the specialty of urology. The Hugh Hampton Young Award, which many are familiar with, provided through the AUA. And then in particular, in 2023, he was awarded the Ellis Island Medal of Honor. It's one of the nation's most prestigious awards, bestowed to Nobel laureates, corporate CEOs, politicians, and celebrities like Muhammad Ali. It celebrates inspiring individuals who are selflessly working for the U.S. and its citizens. So I am delighted to have Dr. Wein. Welcome, Dr. Wein.
Thank you.
So,
appreciate the opportunity.
So for our audience, we're going to get into competition and collaboration in urology. And I think it occurs to me that doctors by nature are competitive. And so I posed the question, why does medicine feel so competitive?
I think that's a great question. I think that by nature, physicians have had to compete basically all their lives. So competing once they reach their professional status is not something new to them. I mean, we have to compete, first of all, getting into college, then one step higher, getting into medical school, then one step higher, getting a residency in whatever you decide to do, then one step higher for many people, getting into a fellowship, then one step higher, and that is securing a position that you really want, whether it be in a large or small practice group or in an academic practice group. So we've had to compete all our lives in getting to where we are. And I think that, so we're by nature very competitive, very driven people. In addition, when we go through our training, let's say from medical school through residency training, through fellowship, we see the institutions that we're employed by competing with one another. And, that competition can be positive, it can be negative, but we see them competing against one another. We look at the tools that we use, whether it be technology, whether it be pharmaceutical agents. And what do you see? Well, we see competition. We see competition with various instruments. Well, how do you do this? What machine do you use? What lithotripter do you use? What laser do you use? Ours is better than yours. Basically, we have a technology, at our institution that makes treatment for this disease better than any place else. Some institutions do that. We have a drug. Our drug is better than their drug because et cetera, et cetera, et cetera. So all around, we look at competition. And there really isn't any set of principles by which the competition is regulated. So I think that's why medicine is so competitive, because wherever we look from a long time back, from medical school, we've been schooled in the art of competition. Sometimes it may be more overt, sometimes it may be unbalanced, but the point is that that's our life.
I'd like to pick up on one thing you touched on that piques my interest, and it's the concept, I think you alluded to, the practice of medicine, and really within the business of medicine. And how do you look at that, as certainly in today's healthcare delivery space?
I mean, medicine, I think, has certainly become more business oriented than it was in the past. In other words, the patients should still be the center of attention. And I think really in most physicians' mind that the patient remains the center of attention, but it does so within a very business-like structure. Whether you're in a small practice group, maybe less so. If you're in a big practice group, I think probably the financial organization is very much like that of an academic medical center. An academic medical center, I think, is a little more organized on a financial basis. And I think many of the things that you do are essentially regulated or controlled by the organization that you work for, as far as the number of patients you're supposed to see, your productivity, whether it be in terms of RVUs or revenues over expenses, whatever the institution feels that you generate in terms of expenses to produce the revenues that you produce. The departmental or divisional structure, the budgets, how they fit into the budgets of the institution, and why certain decisions are made, which when you look at them on, you might consider it a little cold basis, really made in terms of finances. I think that it helps if you understand the organization that you're in, whether it be an academic medical center or a large practice group or a small practice group, what the goals really are as far as finances are concerned. I mean, everyone has the same goals with respect to patient care, shared decision making, et cetera, but the financial constraints and the financial organization may be quite different. And I think that your leadership skills, if you're in a leadership position, will be somewhat prejudiced by what the organizational goals are in terms of finances, patient care, et cetera. I know that Penn did something that was, I thought, quite useful. They basically made all the department and divisional chairs attend a Wharton course that you really had to go to. And actually, it was extremely valuable. So they started out with an overall financial structure of the institution and what the goals were. And then they went into what the funds flow were, the money that you earned in practice or your practice earned, how that fit into the overall structure of the university, the School of Medicine, who supported that, et cetera. So by the end, you understood how things were budgeted and why some things were as they were. And you sort of had to organize your concept of what leadership should be according to those principles, because there were certain things that you could do because of financial constraints, and certain things that you couldn't do, and certain things that were encouraged, and certain things that weren't encouraged. And you knew what the most profitable centers in the medical center were, and you knew what the least profitable ones were. and the ones that had to be supported and the ones that didn't have to be supported. So it was a very useful course. I mean, I think anyone going into a big organization, whether it be leadership or non-leadership participant, would really benefit from that, because you will understand why institutions are so competitive, to get that competitive edge and therefore a financial edge that enables them to do things perhaps that another institution can't, because their finances aren't as well organized and as well targeted.
Yeah, I want to get back to the economics maybe of competition and get your insight on that. I think maybe just a step up from that would be, we've postured a little bit here that competition is bad. Do you feel that way? Do you feel competition is bad? And I think the follow-up to that was, do you worry that some of that is driven by finance, because clinical outcomes, clinical desires have lost their interdependence with financial decisions?
Well, let me start out by saying why I think competition is good. In other words, what are the benefits of competition?
Mm-hmm.
So I think the benefits of competition are that competition brings new technology to the patient population and to the management of diseases quicker than it might occur ordinarily. I think that competition encourages manufacturers of equipment, pharmaceutical manufacturers, to develop tools that can be used in the diagnosis and treatment of diseases faster than they would ordinarily be developed were there no competition. Competition might encourage a particular medical center that was more financially viable to be an early adopter of some new technology that might really could be better than existing technology. Now, they take a risk, and if that proves not to be so, then obviously they take a hit financially. If it proves to be so, that is more effective, safer, then by being competitive and trying to get the word out, they increase their patient population, they increase their treatment episodes, and they become more profitable. So in that way, I think competition is beneficial. I think competition is, or can be, not beneficial because it encourages institutions in some ways to perhaps overstate what they're doing. I mean, the patient is a consumer, and patient doesn't know one piece of technology from another piece. So when someone overstates the efficacy and safety of a particular form of technology for a particular disease entity, and actually there's no near unanimous consensus in the literature or among experts that that's really so, I think that's a disservice. And that's a bad thing about competition, because that's what it encourages. It encourages you to get the edge on the other institution or the other fellow. And I think that part of it is really bad. It's also, it also is very hard, if the institution you work in does that, it's very hard to teach the residents an ethical approach to presenting alternate solutions to a problem. In other words, if the let's call it the shtick at your institution is that you treat A with B, and you somehow deviate from that, you're not on the team, basically. And I think it's a difficult thing to explain to residents, to say, well, you have to be fair and objective, and it's shared decision making, and you really can't say anything, you shouldn't say anything, unless it's pretty well proven and accepted by the world of experts in that particular modality. when the institution is doing something different. I mean, that I think is what makes it bad. And the other thing is it makes everyone, well, for instance, in the pharmaceutical world, it makes certain manufacturers overstate what the potential benefits of their particular treatment is over the other manufacturer's particular treatment. And it's an interesting phenomenon. I mean, it's an intellectual exercise, basically, in pointing out things that, yeah, okay, theoretically may be beneficial, but on a practical basis, it's not. Roger Demikowski and I once wrote a chapter for a book on overactive bladder. Basically, it was how to evaluate and compare one drug to another for the management of overactive bladder. But in essence, what it really could be looked at was a handbook about how to make your drug appear better than the other fellow's drug. And I think that with that sort of stuff, going on, it's hard to discourage people from being competitive because they see that, hey, the pharmaceutical company that has they have to have decent results, don't misunderstand me, but they may not in fact be better than the other person's results or the other manufacturer's results, but they spend a lot of money promoting that and they seem to do better financially. So that, I think, rubs off on everyone.
Yeah, you've made me really appreciate, certainly in resident training programs where everybody ultimately starts and comes from, how the culture of that program and the way they present this and talk about this can really either foster the concepts of collaboration or entrench us into the competition mindset or the myopic views that of doing certain things certain ways. What's your perspective on the economics of competition, and specifically maybe in some reimbursement models, fee for service versus capitation? Do they have a role in this space?
Well, theoretically, they do. And I say theoretically because there are certain things that you do, that I do, that everyone does in their practice that generate more revenue than other things. And they're approved and they pay a certain amount, et cetera. So I think that, yeah, that's the system. And I'm not saying that we don't have the best medical system in terms of ultimate results, but I think what it encourages people to do is you do as much as possible. And there are certain strategies where basically you were taught by courses that are given at virtually, every specialty's meeting, someone has a course about billing and reimbursement, about how to legally bill for as much as you can. In other words, how to bill for everything that you do. And some of us don't do that. I mean, we just want to get out of the office visit as quickly as possible. So, you bill a level 3 or whatever because you figure no one's going to come back at you for that. But there are ways of doing it otherwise. And so I think that most institutions obviously would rather have you bill at a maximal level legally than at a minimal level. And that's, the interesting thing about Epic. I mean, yeah, it's an electronic medical record system, but it's a billing system. It encourages you not to forget anything that might lead to a lower level of reimbursement for the institution or for the practice group that you're in. And you have to remember that when you see patients or you do surgery or whatever, that unless you're in solo private practice, that those revenues are not yours, they belong to the institution. And so the institution may have certain fixed principles about how to do that, and they know very clearly about what's more profitable for them and what's not. So, yeah, I mean, I think it does unfortunately encourage us to do a lot of stuff that may not, strictly speaking, be necessary. In other words, think of it this way. And I'm not saying this is the ideal plan, but it's one plan. If you had X amount of dollars, if you were paid X amount of dollars to take care of a specific disease entity for 1 year, what would you do? In other words, how would you spend that money, or maybe not spend that money, if you think you could take care of it just as well intellectually as by doing a bunch of studies? And so let me pick one thing, okay, in a field that I speak about and write about a lot, and that's lower urinary tract. Just take the field of urodynamics. So if you thought about it in this way, I'm not really going to get paid for this study. Is it really going to do me any good? In other words, should I spend part of that money that I'm allocated to take care of this patient on this particular study? That's kind of one way to do it. Or diagnostic cystoscopy. Do I believe let's say the British literature that an advanced practice provider can do as well trained if they're, intellectually capable, and I think most of them are, to do a diagnostic cystoscopy as I am. Am I going to use them? Am I going to do it myself? In other words, all those things, they sort of promote kind of what we do. And, being busy means doing a lot of stuff. Doesn't necessarily mean doing a lot of stuff that's really necessary. It just means doing a lot of stuff.
Yeah. I love that framing. Doing something, if the incentives weren't aligned financially, would you still do them? And then being busy doesn't necessarily mean you're doing a lot of stuff that needs to be done. If we think about competition on one side and we're trying to balance collaboration and posture towards collaboration, what do you think about that concept? I mean, what advice do you have for our audience around how to balance, but how to be a change agent and posture towards collaboration?
I think that a lot of us have been doing for a very long time what's now a catchphrase. Someone came up with the catchphrase shared decision making, it's a good catchphrase. But I think basically what that means is it's collaboration. It's not just collaboration with the patient. It should be collaboration with your colleagues to get the patient the most balanced view of whatever decision they're trying to make in terms of treatment. In other words, and you can, I think, as a leader, you can shape the viewpoints of the people you train by what you do. In other words, most of my practice from maybe after the first 25% of my tenure was oncology. So I never hesitated to get a radonc, consultation with somebody I trusted about, prostate or even invasive bladder cancer. And the medical oncology people, there are some urology practices that are big enough to have a urologist who's well schooled in medical oncology take care of all those things for metastatic or recurrent disease. We never did at either of the institutions, that I've worked at. And I always respected the medical oncologist's viewpoint and pretty much let them take the lead in terms of treating metastatic or recurrent disease, and the radiation oncology people as well. And for treating initially the primary disease, I always thought it was the right thing to do, and tried to convince the residents that it was the right thing to do, to let other people weigh in and ultimately let the patient make the decision. That's what shared decision making means to me. So I think collaboration is great, and I think sometimes we don't do as much of it as we should. I mean, all of us are schooled in doing certain things. So we may be totally unfamiliar with a particular procedure that is out there and being advertised. I mean, bladder outlet obstruction is a great example of competition. My device is better than your device. And, this is, better than that. This has, fewer reoperations within 5 or 10 years. This one, has a higher differential in flow rate or AUA symptom score than that one does, et cetera. Well, I mean, if you've never done it, a particular procedure, and you want to be fair and the patient wants to know about that because you've mentioned it, you really have to send them to someone who's done it. I mean, there used to be a great advertisement for Guinness Stout, the dark stuff that you drink when you're in England. And the advertisement was, I've never tried it and I don't like it. You can't do that in medicine, I think, unless the opinion in the literature is so overwhelmingly negative about that it's okay to do that. But for most things, it's not that way.
Yeah, I love
collaboration is great. You let the patient hear different viewpoints and let the patient make up their mind. I'm glad someone came up with the catchphrase shared decision making, but it was practiced a long time ago without the catchphrase.
Yeah, that resonates with me. And just, I don't know that I ever framed the informed decision-making process is also allowing and encouraging the patient to see other providers who have expertise you don't. And that's part of your job, your role, to stimulate that shared decision instead of just a one-on-one. I'm supposed to help you and be unbiased in every choice that you're trying to think about and consider, and having the humility to do that. That's very practical advice. Can you give us other examples, maybe for practices, departments, groups? We talked about this exhibiting these behaviors in the moment, shared decision. Are there other leadership qualities to foster collaboration over competition?
I think that people in your particular unit, if you're the leader, and I think that I include in that trainees, I think that practitioners less so than trainees will follow your lead if what you really do, and you have them in office hours or on rounds, you talk to them, about getting other individuals that are knowledgeable about the subject. I mean, we don't have a premium on cancer. There are other people that know a lot about it as well. Let them weigh in on the decision. It doesn't really hurt. I mean, if you have a patient that you think needs a procedure for something, then the next decision is, well, what kind of a procedure do they need? I mean, it's perfectly okay to let other people weigh in on the conversation. And, that applies even to things like, small renal masses that are not so small, that are sort of in between. You say, gee, should we minimally invasive ablate this? Should we do a partial? Should we just watch it? Send them to the IR people. Let them get the opinion from them. It's okay. And especially, again, that sort of fits into the model of, well, what you're interested in is taking care of the patient, and you're interested in taking care of the disease. But it's okay to say to the patient, listen, you decide what you want, and I'm happy to follow you afterwards, along with the person who actually did whatever procedure that you decide on, or if they turn the follow-up to me, I'm happy to do it. I think that hopefully people will follow your lead if you do that and you are pretty vocal about, hey, this is what I do. Other people may not do it, and that's okay. Everybody has their way of practice, but this is the method of practice that I'm most comfortable with.
Yeah. Yeah, I can see a path to that. I mean, I think that resonates a lot with people in the academic departmental infrastructure. What about a non-academic and departmental infrastructure, large urology group practice, or even urologists and smaller groups in the community?
Yeah, I've never practiced in one of those, so I can't really say as a participant. I mean, I can tell you that the large practice groups, I think, are organized very much like an academic department in that they have experts that deal with certain problems. So if you're one of the so-called general urologists and somebody has prostate cancer or whatever, then there's usually an organizational structure that is, let's say, that leans toward one management strategy or another. In other words, if you have your own radiologist or radiotherapist employed by that group, and you have a group of experts who do robotic prostatectomy, then hopefully you'll get an opinion from both of those. Maybe some groups are guilty of referring preferentially to one side or the other because of financial motives. I would hope that's not the case, but certainly a possibility, because after all, they have to financially survive as well. And their budgetary process, I'm sure, is the same as an academic medical center, except they don't really have to worry about, supporting research in any particular field. They don't have to worry about supporting the School of Medicine, which is usually underfunded. They don't have to worry about a lot of the financial constraints that academic medical centers do, but they do have to worry about some of them. They have to worry about paying their bills, and they have to worry about paying the support staff, acquiring new equipment, and paying the individuals within that large group practice what they think they're worth.
Yeah, it sounds like a lot of what you're articulating is, hey, really understanding the incentive structure and the finances obviously is a big step towards thinking about collaboration, and then thinking about within any unit the diverse expertise that is required to collaborate so that you have choices and understanding within that unit of people that are experts in different areas.
Yeah, and I think that, like I said at the beginning, I think it would be extremely useful for everyone who goes into one of those organizations to be given a comprehensive course about, okay, here's the organization. I mean, these are our goals. This is the way it's structured. Okay, here's a dollar that comes in. Here's the funds flow. This is where the dollar goes. You either do or you don't have to support basic research. You do or you don't have to support the School of Medicine. You have to do this. You have to do that. You have to support the administrative structure of the medical center. You have, et cetera, so that you understand when you come in the organization where the money goes. Now, it may not be as favorable as far as putting money in your pocket as another group, but that's the group, and you have to work within that group. In other words, every organization has a culture, whether it's a large practice group, small practice group, academic medical center, and you have to work within that structure. You have to be very careful who or what you're disagreeing with, because if that's the organizational culture, you're not going to change the organizational culture as a single individual. The organizational culture may change you, and it may change you in a good direction, you think, or it may change you in a not so good direction. But that's one of the things you have to consider when you're deciding what you want to do with your career after your residency or your fellowship or whatever.
Yeah, I think that's so thoughtful about, again, what are the organizational values? What are the organizational priorities? And those are going to influence what you do on a step down level, departmental level, or same thing in a urology practice. Really the same structure, the same concepts. What are the priorities of that
Yeah,
organization, and making sure you're thinking through this.
yeah, and I think that you have to be very careful, especially if you're in a leadership position at an academic medical center, because the academic medical center has been there long before you got there, and it's going to be there long after you leave. And so, there's one particular quote that I always remember, and I don't know where this came from. I think it's one of those things that, you list as anon for anonymous, but it's choose your battles wisely. One can slay only so many academic dragons in one lifetime. And I think if you think about the implications of that, and you say, hey, that's true, that, if I'm in an organization and I've joined that organization voluntarily, I haven't been drafted, then I pretty much have to accept the organization's values, goals, etc. And I have to somehow inculcate that in the way that I conduct myself. And I may be able to choose a few things that I can disagree with and not get too far out of the bounds of the institution and doing what I want to do, but can't do that for a lot of them, or else you'll be termed a rebel and somebody who's not desirable for the institution.
Yeah, that's really great stuff. Thank you for thinking through that. As we get towards the end of our podcast here, I would like to take the opportunity just to think about you as a leader. You've had such a distinguished career. You've been in a lot of different environments. I think my question would be, how has your leadership style evolved over time?
Yeah, I think that what you do is you look at people that you respect, and you sort of pick different people whose styles you like, and you try to choose the particular part of their style that you like and put that into your leadership style. So whether you want to call them, rabbis like in the, police force or whatever, but, the people that I always admired, for instance, I have a talk about leadership and it's like 4 pictures. One picture is of Jonathan Rhodes, who was the chair of surgery at Penn for many, many years. And at that, during his time, probably the most respected, one of the most influential surgeons in the world. And, JER, Jonathan E. Rhodes, as we used to call him, had a particular leadership style. It was very soft, but very heavy. I mean, everything Dr. Rhodes said, you had to listen to very carefully. And so he was at the same time authoritative, but very soft-spoken. Joe Kaufman, who was really a good friend of mine, who was the chair at UCLA for a number of years, he had a different leadership style, a little more flamboyant, not a little more, but very knowledgeable, very forceful. Pat Walsh, who was, obviously at Hopkins for many years, he had a different leadership style. John Duckett, who was the chief of pediatric urology at Penn, and, who was really responsible for a lot of the good advice that I got. John had another leadership style, a little louder than some people, a little more on the rebel side for certain things. So I think you look at people and you try to sort of meld what you thought were the best parts of their leadership style into your own. And then you sort of see how that works. And if it seems like it's working, you just continue to do it. But you always give credit to those people. In other words, it's not my style. It's just something that I guess, adopted over the years. And what I was pretty happy with when I was at Penn. I had disagreements with people, but never to the point where, wow, you developed an animosity towards somebody that you kept for a long time. I mean, it was always, friendly banter. And I was able to get along well with people and still disagree with them about certain things.
So I think maybe one final question I have, just to try to extract some of your sage wisdom, some more of your sage wisdom for our audience. For you at this point of career, how do you want to get better as a leader over the next couple of years?
Well, I mean, my position at Miami now is a great position for me. I mean, they have a great chair. They have a great residency director. They have people that are experts in each different field. My position now really has to do with, well, what's now called ERPS. It's changed the name so many times. Urogynecology and reconstructive pelvic surgery. I mean, it used to be called female urology, used to be called a lot of things. So I basically give advice to and mentor the people that actually do the bulk of the work in that field. My practice at Miami is strictly general urology, very general. All the stuff that you don't want to see, all the stuff that I didn't want to see when I was, seeing mostly cancer patients or difficult, complex lower urinary tract dysfunction. And I mentor the medical students, trying to advise them about how to apply for residencies, et cetera, and giving them an honest opinion based on their record as to which programs I think are more favorable for positive consideration for them than others. And the same for residents that are applying for fellowship. And if the chair wants my advice about something, and he's very honest guy, very forthcoming, and sometimes he does actually, and I'm very flattered, but I give him advice based on what I've seen and what I've done and what's happened at other institutions that I was either at, i.e. Penn, or situations that I know of that happened at institutions that I wasn't at, but where I knew people very well enough so that they told me about those situations.
Yeah, it seems to me you've really evolved into this special role of mentoring. And when I think about you and certainly getting to know you here, the word mentorship comes to my mind quite often. Well, Dr. Wein, I can't thank you enough for sharing your time.
One of the great levelers that I found when I directed the residency program at Penn for actually 40 years was that a great equalizer is to tell the residents to call you by your first name. It makes them more of a junior colleague than a student. And I can tell you this, if that really makes a difference. It really does. And if they adopt that, I think that they're much more amenable to listen to what you have to say as a respected colleague, rather than some, teacher that's on a podium, lecturing you about what you need to do.
That's great advice. And that's a great segue to end this podcast. So thank you again, Alan, for sharing your time and expertise with us today, talking about competition and collaboration in urology. And then just a few nuggets from what a wonderful, successful career, still going, and some sage advice around leadership.
Thanks to the AUA for, allowing me to do this.
And thank you to our audience for joining us on the AUA Leadership and Business Podcast.
Thank you for joining us today on the AUA Leadership and Business Podcast. We hope you found today's insights valuable. Enhance your expertise further with the AUA Practice Management and Coding Program on demand, designed to empower providers and coders with the tools to optimize practice efficiency and ensure quality patient care. Visit auau.auanet.org for more information and to register. Until next time, continue to learn, lead, and excel.